And then
Here,
share
open
this,
document.
right? Share webcam.
Okay. Here,
Start
I've missed
sharing.
1 week.
Yes. Start sharing.
I didn't draw anything during your
Start
work.
sharing. And then pull this up.
Is that good or bad?
There you go.
And then we need to turn this way, right?
How's that look now?
Does that look okay?
Would have been here.
In the conference, it was a new conference because I didn't push record.
Mine engine went out. Oh my God.
I think you're good.
Oh,
So
Those
I
are
got
all
stuck
your
at
keys.
Chelsea. Chelsea had to come pick me up at like 9:30 p.m. on Tuesday.
All right, it looks like several people are logging in. Okay.
All right, maybe.
Can everyone hear online this there? Alina, Amy, Emma, Maddie? Can you see the document?
Oh, no, it wasn't helping. It took me that long to.
Okay.
Bye, Vicky. We'll miss you. Bye, Vicky.
What about now? Can you see the document?
Let's see. Have you hit the laptop over there on the?
So you've got it pulled up on your computer, but you don't have it as you're sharing your screen.
Okay, so go back to.
It's little blue button today. There you go.
See, that's what I don't know how to do.
Okay.
I'll move out of the way. So we can do. And if you want, or you can pull it up to so it's got the chat. I didn't know. That's where I get so mixed up. You know what I mean?
Yep.
And so
And I do this today. I know, I saw you. I do a lot today.
you can see.
All right.
And so this is what they're seeing.
Yeah.
All right, I'll get out of the way.
Okay, guys.
Okay. Okay.
Doing antibiotics, right?
Yes.
Anti-infectives,
Yes.
antimicrobials.
They're on the same thing.
They're all the same thing. Exactly. Okay, what questions do we have?
I don't have one. Most of them you answered yesterday when you came in and we were doing stuff.
You came in. What happened?
They had a study group yesterday here and
okay.
had a couple questions, so I came in and answered the questions.
Oh, actually, I also wondered, like, because you came in and I didn't actually get the answer to this. If we had to know whether or not they were broad spectrum or narrow spectrum, and like according to the penicillins, like that was kind of mixed up. I wasn't sure which ones actually were broad. Which ones were
You just need to know the difference between broad and
just
narrow.
know what they do.
Yep.
Got it.
Don't need no specific.
You don't need to know specifically what medication is broad and what medication is narrow.
That helps.
But I will ask you this question. Which medication in the Cillins has a narrow therapeutic range?
Narrow therapeutic range.
Yes.
Ampicillin.
Close.
I don't know.
It has Redman's syndrome is an adverse effect.
Wait.
You have to have a peak and trough. Banco.
Banco isn't a penicillin.
Well, it's a myosin. You're right. But in terms of its, sorry. It has a very narrow therapeutic range. What's another medication that has a narrow therapeutic range?
I don't know now. I'm second guessing.
It is a psyllin. Well, it's a myosin.
Wait, what?
I'm so confused.
Gentamicin.
Oh, that's not a psyllin either.
It's a.
That's a
Yes, you're right.
aminoglycoside.
And
Let's see.
Which one?
Gentamicin.
gentamicin and vancomycin, you have to have peaks and troughs.
So gentamycin's an aminoglycoside.
Aminoglycogen. Yeah, aminoglycogen.
And then vancomycin is a glycopeptide. And they both require mostly troughs, but sometimes peaks because they have a narrow therapeutic window.
Oh, I already wrote that.
Watch out for toxicity.
What happens with toxicity with those two?
Vancomycin, you have hypertension, tachycardia, red band syndrome, which is like the rash all over their chest.
And the flushing.
Neck, face, flushing.
There's one more.
Ototoxicity and
Yeah.
Say it loud so they can hear it. Are you hearing that online?
Ototoxicity and nephrotoxicity. So what kind of things are you going to see in nephrotoxicities?
Nephrotoxicity?
Uh-huh.
Maybe like
If your patient's
malaria?
having problems with their nephros,
Yeah.
with their renal function.
I need like difficulty or like decrease in urine output.
Decrease in urine
So,
output is
sorry.
number one what you're going to see.
All area?
So decrease in output, and then you'll see it in what labs as well. It gets severe.
Yeah.
BUN and creatinine.
It's abbreviated.
Yeah, but that was a.
All nursing students call it BUN, and then
Yeah.
they get into practice, and then it's BUN.
You get slapped.
Nobody likes to hear BUN.
You're like, what?
Bring it on.
Nobody likes it. Okay. What else? Talking about urine output. What's appropriate urine output?
30 ml at least.
30 to 50.
Okay, so let's say 79 kilo patient. What's the urine output for a 79 kilo patient?
Like 2 ml per hour. 1 to 2. I forgot.
That was for peds or something.
Is peds the like 2 ml per kilogram? And then also like if they have and chemo, it'll be also 2.
What about online? Nobody's answering online.
Yeah, I thought it was 1 milliliter.
Amy, I love how you're online and in person. This is awesome.
I know. I was like, wait a minute. Aren't you in here? And here she is.
Okay, so what is an appropriate urine output for a 79 kilo adult person? It doesn't matter if they're adult, actually. A 79 kilo person. What's an appropriate urine output for a 12-hour shift?
Over 12 hours.
Or you could go per hour.
900, 1,000-ish mLs.
I thought they said 10 ml per hour at least.
That's a lot.
It's 1 ml per kilogram. That was like normal for me.
30 to 50 is normal.
Where's Rachel?
So-
Chantel?
That's 80 mils times 12. That's a lot.
948.
That's a lot.
It's gonna be on the exam.
No, and it is something you guys need to know. It is actually. What's the minimum urine output for a patient greater than 30 or less or equal than 30 kilograms? Shelby got it, 30 mils per hour. Well, it is what you said earlier, but then I gave you a 79 kilo person, and then you were thrown off.
And that's the questions that you get. You know this answer. You can regurgitate, oh, it's 30 mLs an hour.
So if
but
they're,
it's applying it to a patient scenario.
you're going to get questions that say, this is your patient, and not just in my class, but in other classes
Yeah.
and on the NCLEX. You're going to say, this is your patient. This is what's going on with them. Their urine output for the last 12 hours is this much. And then you're going to have to answer the question knowing that. So you need to know, you're going to need to know, is that an appropriate output for that patient or not? Okay, so how about how many mils per hour do you want for a 10 kilo kid? Uh-huh.
So that's when it matters. That's when it's 2 ml per kilogram. It was 2. Yeah, I think it was
It's 1 mil per kilo. Who told you 2?
10 mils in an hour.
10. But who told you
It
2?
was 10 or 20.
It's 1 milliliter per kilogram per hour.
Wait, again.
So if it's 10 kilos, then
I know
it's 10
too much
mils.
on chemo, but I thought, okay, I'm lost. It's fine.
I'm a
I just need to
visual person.
review that shit.
I don't care.
It's
Okay.
fine, I'm moving on.
The minimum amount is 1 mil per kilo until they're up to 30 kilos. And then they're considered an adult is 30 mils per hour. So once they're up to 30, then it's just 30. Does that make sense? Okay. So based on how much urine output they have, how many kilos they are, you guys can decide for if it's appropriate or not. Okay. Anything else?
Are you asking for questions?
Yeah.
Yeah.
Any questions? Anything you want me to go over again?
For tetracycline, it says that they get like the yellow-brown teeth discoloration, and it's listed after. It's saying that it's not appropriate for kids under 8. Is that just for kids under 8, or is that just in general?
That's
The yellow-brown color of the teeth.
so it affects your adult teeth. So once they come in, so kids over 8 can take tetracycline because most of them have their permanent teeth in. It's not the most famous drug though, but definitely pregnant women and children cannot take tetracycline or it will discolor their teeth. So Lena, the question was about tetracycline, if kids can take it if they're over 8. Which technically they can, but you're not going to see it very often. There's better drugs for that.
Questions if we would be.
You see the clarification?
Sorry, am I in the way? Okay. Yeah, so go through the clarification document. Let me know if you have any questions on them.
So on what is it, the antibiotics that we were going over yesterday, the ones that have like 5 different generations.
The cephalosporins with the
Yeah,
5 generations.
What in specific do we really need to know about that? That there's just 5 different generations, or like
The 5th generation doesn't even have a med that we need to know, so we need to know about the generation.
So I thought there was.
when we would use those drugs over another.
Bactericidal means it kills.
Right.
Bacteriostatic,
Changes the DNA.
yeah, just kind of clogs it, prohibits it.
Bactericidal will be more efficient then because it's actually killing the bacteria, whereas bacteriostatic is more like neutralizing it.
Yeah, so remember it all assists in the immune system. Remember that little video with the phagocyte chasing the bacteria?
Yeah.
So bacteriostatic helps the immune system by slowing it down, globbing it up, not letting it reproduce. Bactericidal actually pokes holes in it so that its guts come out and it doesn't live at all. And so it helps the immune system that way. Does that make sense?
Mhm.
And you're right, bactericidal seems like that would be the greatest thing to do, but every drug has adverse effects. And so sometimes the adverse effects are greater than the beneficial of killing the cell. Does that make sense? What about online? Is there any question that way?
So Shelby, to go to your question right there, there is a question number 18. What are the pros and cons to narrow and broad spectrum antibiotics? So if you know what narrow and broad spectrum antibiotics do, you should know some of the pros and cons to them.
Yeah, if you know what.
Know what you're treating.
Yeah, they don't need to know what meds go with which, or if they're gram negative or gram positive, but just know
Yeah.
what that means.
I'm not going to say penicillin is what kind of antibiotic, a broad or a narrow. I'm not going to test you on that. I'm not going to say which of the following is a broad spectrum antibiotic. It's more of knowing like the pros and cons.
Then she said something else, Shelby.
Yeah, so taking antibiotics prophylactically. Talked about it in class. When would you take an antibiotic prophylactically? Prior to surgery. Especially abdominal surgery, right? Because like that is especially if they're gonna like cut into your intestines, that is a dirty piece of body part right there.
Yeah. And the most recent evidence shows that if you can get antibiotics on board, and of course this is IV, this isn't PO or IM, this is IV. If you can get antibiotics within 30 minutes of opening up a patient or having surgery, their incidence of infection decreases substantially. So your surgeons, if you're on the surgical floor, if you're in an ER, will order medications, an IV antibiotic to be given, and they put it like on arrival to the OR or
30
right
minutes
30 minutes
before,
before OR time. And that's the reason why. Evidence shows that it decreases post-operative infections if they do it 30 minutes before. And that's the same principle, Shelby, for your dental work. Because the mouth has a lot of bacteria. And if you have any kind of like rheumatic fever or any kind of something going on with your heart, you can get infections in there. And so those patients that are at risk, they give them prophylactic medications.
What about can anyone think of any other time that you would want a prophylactic antibiotic?
Alina asked about one.
Yeah, same thing with deep wounds. They will do that as a preventative. So somebody comes into the ER, they have a god-awful laceration, okay? And even if we stitch it up in the ER, if it's really bad, dirty, contaminated, they rolled their ATV, whatever, we will give them a dose of IV antibiotics and send them home on PO antibiotics. Same concept. So good job, Alina.
So going with that, animal bites too.
Oh yeah, they'll get it.
Mm-hmm.
Yep, animal
Cat
bites.
and dog bites are horrifically infected.
What else? There's another time.
Travel.
What, Amy?
Travel.
Traveling. If you're traveling outside the United States to say Africa, you're probably, maybe some places in Mexico, you're probably going to be put on some antibiotics to prevent different things.
So Shelby, your question, is this just a general or is there a specific drug when taking something prophylactically? This is where your broad spectrum or your narrow spectrum comes in. Which do you think would be better? Definitely broad. Why? Broad spectrum. Broad spectrum. Yeah. Kim was like, what'd you call me?
No, you don't have your touchscreen on.
I had a question about like cultures. If someone comes in, can we start them on broad spectrum, then get a culture?
That's a big, fat no.
Always get the culture first.
Yeah.
Always get the cultures first.
Yep.
I don't care if the doctor says, I want this antibiotic started now. You say, I got to get the culture first.
Yeah. Yep, you have to.
You
'cause it messes up.
You can't even do it while you're giving the antibiotic. Like it is before the antibiotic even touches the patient. Or you'll have an angry doctor. And angry coworkers.
And you have a patient that's not going to be able to get the right kind of antibiotic, possibly, or not be able to have it be effective.
It can delay their care for sure. Not having the right stuff because you don't know what bug it is because messes it up.
I will say this is real life, okay? People come into the ER and they're sick, they're septic, they meet sepsis criteria, okay? We have a short period of time to get cultures. We're going to get blood cultures. We're going to get a urine sample in case to see. We're trying to find why they're infected. But we start antibiotics after the culture. And we start broad spectrum antibiotics. We start Zosyn, we'll start Rocephin, and then we will follow it up with Vanco and azithromycin. And then they're admitted into the hospital. But we always have to get the cultures.
Okay. Mark, to go back to your question about the cephalosporins. So I'm not going to require you that you know what drugs go into which generation, but
I had to know that. Gosh, you guys are lucky.
but know kind of the difference between generations. Does that make sense? I mean, they cover the generations for a reason. So kind of know the difference between each generation and kind of why you would maybe pick one over the other, or what the benefit is picking like a 5th generation over a 2nd generation or something like that. Okay. I mean, not too in depth, not too detailed, but just.
On the PowerPoint, you just said it was like either after every generation, it was like even more broader than the past one. So it's just like increasing the broad spectrum.
Some of them, yeah. Some of them, I know some of them are like IV only. So just read through your book, just kind of get an idea of what the differences are. Yeah, some of them can cross the blood-brain barrier.
Yeah.
Some of them can't.
For the generation 5, we need to know ceftaroline. It's not on our med list, but
If it's not on your med list, then you won't get tested on that specific med. Now, classifications are fair game. Individual drugs, just what's on the med list. But if you know the generals of the classifications and you know that drug belongs to this certain classification, should be fine.
And that's the take-home point. There's always going to be new medications. But if you know how a penicillin acts, you know what the adverse reactions are, you know what they're generally indicated for. When you get this new drug that you're like, what the heck is this? And somebody says, oh, you look it up, it's a penicillin. Oh, okay, I got it. I know how penicillins react. I know how cephalosporins do it. I know how fluoroquinines or quinons do it. I know that. Because there's always going to be new meds.
Yep.
They're going to be grapefruit juice. Grapefruit.
Maybe not.
Okay. I feel like that wasn't going to be answered, but Ooh, I have all the questions about echinacea.
I bet you have all
Yes.
the questions.
Yeah.
You guys,
Although,
please
Amy,
go
did
through
you
your
do-
handout.
You did yours on garlic, and didn't you miss the question or something? Yeah. So know your handouts, people.
Go through. I'm not going to throw out any CAM questions just because you guys didn't go over it.
I had practice questions in my presentation.
Her presentation was like maybe 7 minutes long. So if you need to, go watch it again. If you want to just go over the handout, I try to get something that's covered in the handout and the presentation. So you should, either way, be able to get it.
I thought about adding those practice questions in my handout, and I was like, no, it's in the presentation.
You got it. What are common side effects for each classification of antibiotics?
Diarrhea.
Non-involving diarrhea.
Yep. Okay, any other?
Looks
You
like
guys see all that?
Shelby's. I guess my computer doesn't like scroll down. Shelby's wrote something.
I don't know. I think it's down as far as
Maybe not.
it'll go.
Maybe she typed and then she had to stop.
Oh, okay.
Sorry, anyway.
Oh, you're fine.
It's small. Do you want me to go to the other?
I can always pull it up, but I'm just having notes writing as well.
Ooh, that's a good question. In which class of antibiotics is a true allergy likely to happen? What do you think?
What?
Penicillins.
Yes, penicillins.
And one of the reasons is because from my generation, I grew up in the 60s, so I'm as old as your parents, probably older than your parents. And we were given penicillin when we had a sniffle. And so it created this whole generations of people who, when we did actually need medication, that we were resistant to it. And so that's one of the reasons why they have to keep getting newer medications, because of the resistance that's then passed on genetically and through the genes and all of that.
And that's just because they were giving it out like
Yeah,
nobody's
Yeah,
business.
exactly. We were
So
giving it for a sniffle when we shouldn't have. We should have had what? What do you do when you have a sniffle? Allergic rhinitis. What do you take?
Buttercup.
Chocolate and peanut butter always cures everything. Vitamin
Respiratory was a few things ago.
Vitamin
Yeah.
C.
Vitamin C,
Zinc is amazing, guys.
zinc,
I love
non-farm stuff, right?
I think I read in there that
Decongestants, antihistamines, not
Vitamin C?
antibiotics.
vitamin C, as in Charlie.
Yeah.
So would you say that the penicillins are also the ones that you're most likely to develop a oh my god,
Resistance.
yeah, resistance.
Yeah,
Yeah.
yeah.
Because
That's hence
Yeah.
the reason
Well, we
why
talked
we
about
have
penicillin G and penicillin V.
MBK. Yeah.
Yeah.
or even like amoxicillin, that's the one that's generally
Mhm.
like, distributed. Like,
And that's why amoxicillin, that's why when Augmentin came out, that's why they developed Augmentin, because the bacteria was becoming resistant. Like I talked about the beta-lactamase enzyme that the bacteria.
And so what teaching would you give a patient about if they're getting sent home with a prescription of antibiotics? What would part of that be to help decrease resistance of the antibiotic? What would you say to them?
Finish your damn antibiotic.
That's probably the most important. If you had to tell someone one thing about their antibiotic,
Finish it.
finish it.
Yeah,
Don't share it.
yeah.
Don't share it. Don't stop. Finish it till it's all gone.
And that's the problem. We start feeling better, and then people are like, "Oh, I'm great. I
Right,
don't need
Maddie.
to take this anymore." And so then they end up having some antibiotics in their medication cabinet. And then when they get a sore throat, they go back and take the rest of it that should have been, and the sore throat could be viral. And so they end up giving themselves resistance to antibiotics, or they become allergic to it.
Okay, real quick. Shelby asked about super infections. How would a nurse know if a patient has a super infection?
We're not getting any better.
What's a super infection?
MRSA, C. diff, and staph. Those are three.
So those are super bugs.
I have those in the house.
Like, who can tell me what a super infection is?
Fever.
Probably get a fever with them sometimes, maybe.
They're impossible to control or cure. Difficult or impossible to control or cure.
No, those are super bugs.
One that is resistant. You say, Shelby.
Okay, think about what an antibiotic does. When you take an antibiotic, what does it do? It kills. Does it kill good? Does it kill bad? It kills all of the. It's not selective. It doesn't care.
When your regular flora is also killed.
Right. So your regular flora is also killed off, and then you have your opportunistic. Yes, that's what I'm looking for. Thank you. Your opportunistic bugs that come in that wreak havoc.
But you're saying C. diff isn't one of those?
No, it can become one of those. Yeah.
Yeah.
But no, like MRSA, CRE, VRSA, those are super bugs.
Yeah, but you can still get
Not
C. diff from
super-
super infection because your normal flora in your gut has been
The C. diff would be the super infection.
okay. Then yeast infection, I remember that one. I don't remember the other one.
Right, Shelby, when the antibiotic kills all the host flora, so then you have your opportunistic pathogens, because we all have E. coli in our system, right? We all do. We all have staph on our skin. We all have yeast,
Mhm.
women in our vagina and in our mouth. And so, you know, when that balance between good and bad is disrupted, then the opportunistic pathogens can come in and wreak havoc. So what kind of symptoms, how are we going to know if our patient has developed this super infection?
Yeah.
Okay.
They're really sick.
Well, where's all your normal flora?
It's in your intestine and your vaginal.
Okay, so what are you going to get? Diarrhea,
Yeah, nasty.
vaginal discharge, a yeast infection.
Odor.
What about in the mouth? Thrush,
Thrush.
which is a yeast infection in the mouth.
Yeah.
What else? There was one more on my slide.
Yeah, the white tongue is thrush.
Yeah, like white patches. Babies get thrush a lot from breastfeeding.
Painful urination, bladder.
Right. Yep. Painful
UTI.
urination and bladder stuff. You can potentially get a UTI with that. Okay. So those like 4 things. So that's how you would tell if your patient comes in. And like I said, with any antibiotic, diarrhea is kind of expected. But there's a difference between normal diarrhea and C. diff.
Yeah. Once you smell C. diff, you'll never
There's
forget
no
it.
forgetting. Like you
Yeah,
will walk into a room
never.
and be like, they've got C. diff.
Yeah. And it's so contagious.
Same with rotavirus. Rotavirus has its own look and smell, and you can just tell it's rotavirus.
You know what? I can handle C. diff. I can't handle GI bleed.
But no,
Yeah,
those
those
have its own specific smell too. So,
That's what we're going to talk about tomorrow. Yay.
okay.
Absolutely hate GI bleed. Can't handle it.
The question is asking, it says to how to identify supervision. It's just
Yeah.
asking how to tell if your patient has one.
Yeah, how you would identify if they are having bladder pain,
Difficulty.
vaginal discharge, diarrhea, white patches. All this signs and symptoms of a super infection.
Clarify that.
Yeah, how would a nurse identify? It's like the same. How would you identify a cold in yourself? Right. Signs and symptoms, right? You got a cough, you got a runny nose, maybe a throat tickle. You know, you're going to tell yourself, oh, I think I have a cold.
Because it depends on what super infection you are talking about. So if it's C. diff, of course, you're going to have diarrhea. If it's like a UTI or bladder infection, you're going to have difficulty urinating, painful urination. Or if it's yeast, then you have
Yeah.
thrush or vaginal discharge. Yep. You have to get like the yeast underneath like breasts and the penis.
And that's also because yeast is on our skin.
Yeah.
And staph is on our skin. And
But
so
you're more susceptible to get it because you're not.
yeah, it's moisture, it's dark. Remember, bacteria likes warm, moist, dark places, and the body is the perfect medium to grow bacteria.
Or is that more like a cleanliness thing?
It's both.
It's
Yeah,
both.
it's both.
People normally don't get like skin staph infections with antibiotics just because they're taking a shower and cleaning. So it's more the internal stuff like the bladder, vagina, the gut, the mouth.
You got it.
This is a pretty straightforward unit, guys. This is nothing like cardiac and vascular.
Yeah.
It's very straightforward.
And just know what you would teach your patients, whether they should stay out of the sun, whether they should take other forms of contraceptives.
No.
Yeah, what's
Whether
that
they
question?
should-
What happens when you take antibiotics and you're on birth control?
makes it ineffective.
Yeah, I have a son named Aaron because of that situation.
Oh, did you tell them?
Yeah.
Now, just to clarify, now I know we've talked about that a lot, and I swear if you guys get the question wrong, I'm gonna like hunt you down and haunt you for the rest of your life. There you go. But just so we're clear, it is not just a form of contraceptive while you're taking the antibiotic. It's the whole month. It disrupts everything.
Well, it's using your system for a while.
So yeah, so if you've just started if you had your cycle last week and you're starting antibiotics, you better be careful the rest of the month until your cycle starts again.
Wasn't it your daughter that was on a steroid and
Yeah.
an antibiotic? She was allergic until after she stopped.
Yes. Yes, that was so crazy.
Yeah,
Because
makes
that
sense.
antibiotic, it stays in the system. So another thing, there are,
I don't know, maybe that's crazy.
so there are, how do I say this? Let's see. What am I trying to say? What am I trying to say? Yeah, go ahead.
So.
Say it loud.
I think we already like mentioned this, but what situation would we use like a bacterial static over a bacterial cycle?
Oh, that's a good question.
It's like based off the side effect or like when, I just want to know what situation we use one over the other.
Okay, let's think about it. So situations where you would use a bactericidal versus a bacteriostatic or vice versa. Can somebody think of when you would want to use a bactericidal drug over a bacteriostatic?
Bactericidal first, but like if they're resistant to that drug, maybe a different drug, but bacteriostatic would be a better option. If bacteria's responsive to bactericidal.
Any ideas online when you would want to use a bactericidal?
Not necessarily wrong. but
It's not necessarily wrong.
You can type it in, see if it's
But-
more correct. No.
No, it's not necessarily wrong, but we don't always want to necessarily go straight to a bactericidal.
The big guns.
It kills everything, right?
Yeah, because it kills everything.
So that would be like the more like the broad spectrum, where bacteriostatic is more like narrow.
It kind of depends on the drug and the mechanism of action. Like, because some big drugs are really good, but like, for example, azithromycin's a really good medication. It's really strong, but it inhibits protein synthesis. So it doesn't necessarily kill them. It's more of a bacteriostatic, right? Let's think about this. What does a bacteriostatic do?
The DNA of the
Okay, slows it from multiplying, right?
Right.
Slows the growth of bacteria. So what? So then what happens? Right. So then it gives the body's immune system chance to help fight it off, right?
Oh, is this when you have like immune compromise? Am I right? So
That's where I'm going with this.
So if you don't have the cells to go after the pathogen, then that's when you want to kill it because your own body can't do it itself.
Exactly.
Versus
So
the
one
antibiotic.
reason why you would want a bactericidal versus a bacteriostatic is
Bactericidal is when you're immune compromised.
you would definitely want to pick a bactericidal if you're immunocompromised. Okay. A lot of this, honestly, picking the antibiotic really depends on the sensitivity of the culture. It really depends on what drug the bacteria is sensitive to that will kill it or slow it down, what will be effective. But in an immunocompromised person, if you have a choice between a bactericidal versus a bacteriostatic, pick the the doctor is going to want to pick the bactericidal one.
Give your body a fighting chance.
Yeah. In a normal healthy person, it would probably just depend on cost Cost and availability of the drug, really.
And they
because
collect a lot of information about drugs. And so like azithromycin is gorgeous when you're talking about a respiratory infection. I mean, it's just like that. But there's other things like Bactrim and things that are great for UTIs. And so they have a lot of information. And so the physicians will, go with that, wait for the sensitivity to come back, and then change it if it's resistant. Does that make sense? Sorry, you had a question?
Yeah, it's on a different topic though.
Okay.
Go ahead. I think we're done.
So when it comes to the 5 different methods of action, which ones are considered to be bactericidal, which ones aren't bactericidal? Just something we can talk through a little bit.
Yeah.
So number 1, the inhibit cell wall synthesis, that's bactericidal. Yeah.
So, yes, I believe most of them would be bactericidal.
Inhibit
Alteration.
protein synthesis.
Membrane permeability. They've got more pressure inside the bacteria than outside. So if you poke a hole in it, it's like a balloon. The inside will come out. So if you're altering the membrane permeability, that's going to destroy it. And then protein synthesis. So some of these, depending on how much they alter it, it really could, because some drugs in are bacteriostatic versus bactericidal, and I think it really just depends on how much it affects it. You know what I mean?
And
Does that make sense?
You can Google, is this bactericidal or bacteriostatic? And it will pull up. The actual drug will say how it works and if it's bactericidal or bacteriostatic. And I don't know. I haven't seen all of the test questions yet today, but I would think it's more, again, your blue boxes, teaching, nursing guidelines.
Knowing the difference, really. Just
Yeah.
knowing the difference of bactericidal and bacteriostatic. Knowing the difference of narrow versus broad.
So is inhibiting protein synthesis, is that static or cidal? Sorry. It could be both, right? Depending on how much.
I think it could be both depending on how much. If it just inhibits some of the protein synthesis, it might slow it down. If it affects it a whole ton, then it might actually just kill it. It might kill the bacteria itself, or it might prevent it from replicating. Does that make sense? It just depends on how severe it works, I guess.
Yeah.
Like, never mind, that's violent. That's a violent metaphor. Never mind.
It's Halloween.
I was gonna say it's kind of the difference of like punching someone in the face versus hitting him in the head with a blunt object. Yeah. So like one of them's just gonna slow it down. I mean, you're doing the same thing, right? You're hitting them. It's doing the same thing, but it's just the force.
By the way. Yeah.
What? I told you it was violent. See, now it depends on the guy. It depends on the bacteria.
That's right. That's right.
There's a lot of factors that go into this.
That could be a learning activity.
Learning activity. Okay, real quick, just one more thing. I do want to just touch on like azithromycin. Tell me what you know about azithromycin.
Long half-life.
Anything else?
Increased risk for dyspnea.
Potentially. Let's see what I have on here. Side effects: nausea, vomiting, diarrhea, superinfection, hepatotoxicity,
Bacteriostatic.
or respiratory infections, STIs. One that never mind.
We don't need to know that part.
Skin infection.
Back up.
The long half-life. So if it has a long half-life, do you have to take it every 8 hours?
And that's, azithromycin is also known as a Z-Pack. That might be familiar to you. Have anybody of you had a Z-Pack before? How many pills do you take? Yeah, yeah. And it has
It's for
such
5 days, yeah.
it has such a long life that
That's
that's
right,
all
Wapu.
is necessary. And it clears, like I said, it clears up respiratory infections really quick. When
Okay, you sound like you just like had a Z-Pack just recently.
when we treat STIs, we do
She's got it
Losectin
down.
and we do azithromycin.
And then there's a tri-pack. Can you guess what that one is? There's 3 in there. You take it for how many days? 3 days.
Mhm.
And it actually stays in your system for 9 days or longer.
Yeah.
Yep.
Yeah.
Oh, okay.
Yeah. For a doctor, we prescribe it a lot.
Yep.
Yeah.
Okay, any other questions? Anything I need to clear up? Any confusion? Know that you can always text me throughout the day.
No, I'm only to immunoglycosides on my notes. I'm at 7 pages.
Okay,
Minimum.
all right. I'm going to sign this out.
Good luck. We're rooting for you. We know you're going to do this.